Hello everyone, welcome back. My name is Dr. Vijay Bhatia and today we are going to talk about general criteria for dementia diagnosis. Dementia is a syndrome. That means it is a collection of symptoms. Dementia is a syndrome due to disease of the brain, usually of a chronic or progressive nature, in which there is disturbance of multiple higher cortical functions, including memory, thinking, orientation, comprehension, calculation, learning, capacity, language, and judgement. These all are higher cortical functions, and these all are affected in one or the other way. Either one is more than the other, but some of these or all of these are affected to some degree. Consciousness is not clouded when we say this, that the person is fully alert, in the sense they respond to the voice, they respond to the touch, and they are fully awake. The impairments of cognitive functions are commonly accompanied and occasionally preceded by deterioration in emotional control, social behavior, or motivation. So sometimes what happens, they start feeling low in mood, depressed, or their mood becomes labile. Sometimes they can't control how they feel, sometimes happy and sometimes sad. So it becomes emotional upset, and this can precede the symptoms, or sometimes afterwards these things get affected, and including their social behavior. They tend to isolate and not meet as often as they would normally, and there is some lack of or alteration in their motivation to do things, especially for the people who used to love doing the gardening and other stuff, but then they will stop doing those things. This syndrome occurs in Alzheimer's disease and in other conditions, primarily or secondarily affecting the brain. So either directly the disease of the brain, um, like Alzheimer's disease, or brain is affected secondarily, like Parkinson's disease or Huntington's chorea. The disease is somewhere else and then affecting the brain. There are certain criterias, 4 criterias, and we will go through each of them one by one. The first journal criteria for dementia, that there is evidence for each of the following. Number one, there is a decline in memory, which is most evident in the learning of new information, although in more severe cases, the recall of previously learned information may also be affected. The impairment applies to both verbal and non-verbal material. The decline should be objectively verified by obtaining a reliable history from an informant, supplemented, if possible, by neurological tests or quantified cognitive assessments. The severity of the decline with mild impairment as the threshold for diagnosis should be assessed as follows. So what we are saying is, the first thing is there is a decline in the memory, especially the new information is not retained, and in more severe cases recall of previously learned information may be affected as well. And this should be both verbal and non-verbal, and this should be assessed objectively, and verified doing some kind of neurological tests or cognitive tests by the psychologist to identify the areas in which the higher cognitive functions are not to the standard. Mild dementia. The degree of memory loss is sufficient to interfere with everyday activities, though not so severe as to be incompatible with independent living. So in this, the person loses some things and forget certain names, forget certain appointments, but in general is capable of living independently. The main function affected is the learning of new material. For example, the individual has difficulty in registering, storing, and recalling elements involved in daily living, such as where belongings have been put. They might put their house keys somewhere and then can't find, put their glasses somewhere and then can't find, but later on can find. Social arrangements, so they may not keep their appointments with their doctors, dentist, or other places, or meeting their friends, or information recently imparted by the family member is telling that I'm going to come and visit you on Saturday, and the patient doesn't remember. So that is mild dementia. Moderate dementia. The degree of memory impairment loss represents a serious handicap to the independent living. Only highly learned or very familiar material is retained. New information is retained only occasionally and very briefly. Individuals are unable to recall basic information about their own local geography, what they have recently been doing, or the names of familiar people. So if you ask them where do they live, what are the landmarks nearby or shops nearby, they may not be able to recall everything. They might tell you their own house number and name of the street, but other landmarks they might forget. Severe dementia. The degree of memory loss is characterized by the complete inability to retain new information. And this is objectively tested if you ask the person to remember 3 words, or ask them to remember an address. They may not be able to recall or remember or even register the information. Only fragments of previously learned information remain. The individual fails to recognize even close relatives in severe dementia. Criteria 2. A decline in other cognitive abilities characterized by deterioration in judgment and thinking, such as planning and organizing, and in the general processing of information. So in criteria 1 we did about the memory, and in criteria 2 we are doing about the other cognitive functions like judgment, thinking, planning, organizing. These things are affected. There is evidence for this should ideally be obtained from informant and supplemented if possible by neuropsychological tests or quantified objectively with assessments. Informant, usually somebody who is living with the person, like a spouse or close relative or friend who knows the person well, and they can document that person's memory has declined and other higher functions has declined. Deterioration from a previously higher level of performance should be established. The severity of the decline with mild impairment as the threshold for diagnosis should be assessed as follows. Mild, the decline in cognitive abilities causes impaired performance in daily living, but not to a degree that makes the individual dependent on others. So the person is still able to live independently, can do their shopping, can do the cooking, make a cup of tea, sandwich, and remember to take the medication on time. So they are still independent. Complicated tasks or recreational activities cannot be undertaken if you ask them to book the appointments with the doctors or others. They might find difficult to remember and calling them back, or other recreational activities. Moderate decline. The decline in cognitive abilities makes the individual unable to function without the assistance of another in daily living. So even things like cooking, cleaning the house, changing the clothes, and those kind of things, they become important, including shopping and handling money. There is a decline in that they are unable to function these things. Within the home, only simple chores can be performed. Activities are increasingly restricted and poorly sustained. Severe dementia. The decline is characterized by an absence or virtual absence of intelligible ideation. The overall severity of the dementia is best expressed as the level of decline in memory or other cognitive abilities, whichever is the more severe. For example, mild decline in memory and moderate decline in cognitive abilities indicate a dementia of moderate severity. Awareness of the environment, that is, absence of clouding of consciousness, is preserved during a period of time sufficiently long to allow the unequivocal demonstration of the symptoms in criteria 1. Remember, in the criteria 1 we were looking at the problems with the memory, then higher cognitive functions. Then criteria 2 we are saying that there is clear consciousness and there is no clouding of consciousness. When there are superimposed episodes of delirium, delirium is acute confusion, the diagnosis of dementia should be deferred to see if the delirium improves and the memory improves. Criteria 3. There is decline in emotional control or motivation, or there is a change in social behavior manifest as at least one of the following. So there is emotional lability. That means for no apparent reason the person can start laughing or feeling happy, and for no apparent reason the patient might start feeling sad and crying, and there is some kind of lack of control over the emotions, and sometimes the person may not be able to explain why they are doing this. The other symptom is irritability. Patient becomes irritable for short things. Don't tell me that, or get upset easily. Apathy, or they don't do anything. They ignore themselves, they neglect themselves and just want to sit and don't feel motivated at all. And there might be coarsening of social behavior, that if they meet other people they will become more defensive, or they will become more, sometimes even easily upset and don't want to meet people, even the loved ones. Criteria 4. For a confident clinical diagnosis, the symptoms in criteria G1, like we're talking about the memory here, should have been present for at least 6 months. If the period since the manifest onset is shorter, the diagnosis can only be tentative. So main criteria is the memory problems, and the symptoms must have been present for at least 6 months. If the period is less than this, the diagnosis is only tentative, meaning that you should assess the patient again later on, and keeping this as the baseline, and notice if there is any decline, and ask the informant for any other information about the higher cortical functions, and also do the objective neurological test, very often CT brain scan or MRI brain scan, and to look at the causes and to identify the shrinkage of the brain and the ventricles being dilated. Uh, so these are the criteria, and do some kind of psychological testing. The most commonly used one is the ACE, Edinburgh's Cognitive Examination, and at the moment it is 3 or even 3R that has about 100 questions, tests the number of orientation, concentration, short-term memory, long-term memory, fluency, and it is a good test to give the overall picture, and there is a cutoff point. If that is not severe enough, that can be like a standard for comparing for the next assessment. Diagnostic notes. The diagnosis may further be supported by evidence to other higher cortical functions such as aphasia, agnosia, and apraxia. What is aphasia? Aphasia is an inability to comprehend or formulate language because of damage to specific brain regions. And in dementia, normally they find difficulty in finding the right word to express themselves. They know that they know the word, but it is not coming out, and it is frustrating to them. So word finding difficult, or difficulty in finding the right word, or even expressing the right word. The other one is agnosia. Agnosia is the inability to process sensory information. Often there is a loss of ability to recognize objects. So if you place a coin in the person's hand and ask them what is it, they will fiddle with it and may not be able to tell whether it's a 10p or 50p coin or £1 coin. So they might get slightly confused, and they can get confused with the sound as well, some shapes as well, or even some smells. While the specific sense is not defective, if you test the sense as such, there is no defect there, nor is there any significant memory loss. Apraxia. Apraxia is a motor disorder caused by damage to the brain, specifically the posterior parietal cortex, in which the individual has difficulty with the motor planning to perform tasks or movements when asked, provided that the request or command is understood and the individual is willing to perform the task. Normally we ask the person, can you show me how will you comb your hair? How will you peel the orange? So similar things, and they will understand what you are saying, what the command is, but they will not be able to coordinate those movements properly. And in dementia, all these things can happen because dementia is a global, all the parts of the brain will be affected. So parietal lobe, frontal lobe, occipital lobe, temporal lobes, hippocampus, they all are affected to some degree, but certain areas can be affected more than the others. So it is a global cognitive impairment in dementia, especially in Alzheimer's disease. Common causes of dementia. As we said, the most common cause is the Alzheimer's disease, and if it happens before the age of 60, we normally call it early onset dementia in Alzheimer's disease, and if it is a late onset, more after the age of 65, more after the age of 60, then it is Alzheimer's disease in late onset. There might be atypical or mixed dementia when there is a clinical picture that is mixed with some kind of small vessel disease or vascular dementia, and there is also evidence of the progressive illness of Alzheimer's disease. So it is mostly a mixed picture of Alzheimer's and vascular. The other commonest cause of dementia is vascular dementia, and vascular dementia can be acute onset after a single major stroke. It has affected a number of brain areas, and the person is having problems with the memory and other cognitive functions of the brain. Or it can happen in multi-infarct dementia, In multi-infarct dementia, there is over a period of time the person is suffering from high blood pressure, high cholesterol. Over a period of time, the patient is having mini strokes or transient ischemic attacks, and these mini strokes have gathered over the years and they have caused now dementia. It can be subcortical dementia, which will be mostly in the deeper parts of the brain, and it can be cortical dementia and a mixture of cortical and subcortical vascular dementia. The other causes dementia in diseases classified elsewhere, like dementia in Pick's disease. This is a frontotemporal dementia, where the main problems will be patient is becoming impulsive. Everything he is trying to get to the mouth, and there might be problems with their bladder, urination, incontinence. Creutzfeldt-Jacob disease is like cow, mad cow disease. It is a very progressive illness and it's a viral illness which affects the brain. The brain becomes like a sponge, and it is very aggressive disease, and normally it kills the person quite quickly. Parkinson's disease dementia. In this case, normally the person is suffering from Parkinson's disease for a long time, and then later in the later life, and they tend to develop cognitive impairment with memory problems and other higher cognitive functions, and they develop Parkinson's dementia in Parkinson's disease. But sometimes Parkinson's symptoms are not that evident, and it can happen in the early stages, and it is also common in patients with Lewy body dementia. Again, these are Lewy bodies, are bodies in the brain which causes disturbance to the higher cortical functions and the memory. HIV disease can cause dementia. Carbon monoxide poisoning can cause dementia. Cerebral lipidosis, large amounts of lipids, fats in the brain. It's called cerebral lipidosis, can cause dementia. Epilepsy is known to cause dementia. Journal paralysis of insane. This is used to be a syphilis caused illness. In the later part, it becomes the person develops dementia. Vitamin B12 deficiency can cause dementia. This is reversible cause. If you give the vitamin B12 quite early enough, that can improve the ability to, but however, the evidence is that despite B12, it continues to be progressive in some cases. So be careful with this one, and make sure you do the blood examinations and give the regular vitamin B12. Folate deficiency can cause dementia. Wilson's disease this is a disease where the copper is excess in the blood, and it can cause hepatolenticular degeneration, and that can cause dementia. Hypercalcemia, if the calcium is very high in the blood, that can lead to dementia. Hypothyroidism, low thyroid condition can cause dementia. Acquired, this is normally acquired, not congenital, because it is in the later life. Some intoxications, heavy lead poisoning or heavy other metals or some gases, can cause dementia. Even alcohol in the later stages can cause dementia. Multiple sclerosis, another neurological condition. Neurosyphilis, niacin deficiency, another important one, causing the pellagra, that can cause dementia. Polyarteritis nodosa, in the arteries there are nodules. Systemic lupus erythematosus, this is connective tissue disease, can cause. Trypanosomiasis, this is mostly in African countries and South American countries, where CC fly bites. It is a parasite of protozoa that can cause lymph node enlargements and blood in the urine, and can cause dementia. Other dementias like subdural hemorrhage can actually lead to dementia, but this can be reversible if it is managed and treated quite quickly and early. Same with normal pressure hydrocephalus. This can be reversible in some cases if the treatment is given on time and shunts are put in the brain to relieve the pressure in the brain. There are some types of local brain injury or diffuse brain injury can cause dementia as well. Thank you for watching this. If you like this video, please press the like button, share with your friends and subscribe this channel. There are more videos on mental disorders, symptoms in mental disorders, and mainly to understand the diagnostic symptoms. I see you in my other video.